available to you if you've got some questions. But I'm going to invite Margaret now to talk about the work that we did after we found these two publications and found Yasmin and her team's work. So over to you, Margaret.
Thanks very much, Claire, and thanks to you, Yasmin, for your presentation. I just want to talk a little bit about our history in thinking about indicators and frameworks which we had already begun to consider early in the project. And that partly stems from work I've been doing for the last 12 years with the World Health Organization and particularly the Pan American Health Organization, as well as within Canada, to articulate what indicators can do to help reduce, acknowledge where there are inequities, and perhaps be used to measure changes in reducing inequities. So there are lots and lots of resources you can find about what makes a good framework, what a framework means, and what are good indicators. There are plenty of reviews. Back more than 20 years ago, and Ben Schoening are a couple of authors who have landed on these 5 overarching qualities of good indicators, that they are relevant, meaning they're meaningful and familiar to not only the people who are producing them, but the users, and by extension, community that might be involved in the development and use of the indicators. They should be well defined, they should be valid and reliable and can be used over time. They should be what's called in the international language technically feasible, which means you can gather the data. It would be possible even if it isn't being gathered yet, and that they can be usable. And in fact, there can be a 6th category, which would be keeping the sheer number of indicators at a manageable level so that it actually continues to be meaningful. And additional work has pointed to the value of cross-tabulating quantitative data. So when you have indicators that are numerical measures, to be able to continue to slice and reslice them if you are interested in particular populations, if you are interested in particular regions, particularly in a country like Canada where we have national level indicators tell one story, but we know that the story can vary considerably, rural and remote versus urban Canada, north versus south, and so on. And as Yasmin alluded to, the indicators only indicate, so it is essential to seek and use other research and community evidence to support what is known and understood and to help interpret what the indicators point to. So all of this information we brought to our project. We also, in our work, did a bit of a scan at the time, and this was in April, May, and June, of who was thinking about the same kind of information and quick reference sheets. So we found a few checklists at the time that were developed out of Australia, from the US and Europe, as well as from the Pan American Health Organization and the CDC. So it was not surprising, really, that other folks were thinking along the same lines as we had been. So this is the document itself. Claire has already given you a bit of the history and the methods that we used initially. We did not intend to do a comprehensive or systematic review of documents, but kept it at a high level to think about and find the documents that reflected the national perception of and consideration of health equity and disadvantaged populations. And we were fortunate that colleagues inside the Government of Canada, FAC, provided us with some unpublished summaries along the same lines, where they had been drawing up the threads of recommendations from past disasters and pandemics to understand what was needed to sustain and support public health and the population. So it's not a systematic review, but it does as well include some, not only the highlights of the features of what was found in the Naylor report and the other documents that Claire described, but also how Canada has moved forward in at least trying to articulate how we want to improve health equity. There are a couple of reports from the Chief Public Health Officer, particularly in the last few years and even the last few months, that we can return to and look at. Canada has a sex and gender-based analysis policy for the entire health policy portfolio, and in fact is a signatory to numerous international documents on sex and gender-based analysis. Often also included in that is an intersectional analysis. We have the Truth and Reconciliation Commission report and its many, many recommendations that are very important. And Canada has at last signed onto the United Nations Declaration of the Rights of Indigenous Persons. We also have Canada's recent recognition of the International Decade for People of African Descent. And these are just a few of the documents that have begun to point us more in the way to how we can actually articulate our desire to reduce inequity and improve health equity. So we very much, as you've already heard, built on the work that Yasmin and her colleagues had developed, and what we felt would be most useful was to use that framework that she had and her 67 indicators, provide additional prompts that would stimulate the thinking about and the action towards integration and involvement of populations and persons who might typically be disadvantaged wherever we live and no matter how they interact with our systems. So as a couple of examples, if we look at Indicator 7 under the heading of Governance and Leadership, the original indicator by Khan and her colleagues is the public health agency or organization is a member of a local or regional multidisciplinary structure that aims to reduce community risks to emergencies and disasters. The network partners involved in this structure may include transportation, planners, industry, local and regional elected officials. So here in this case, we added a prompt to help us all think this through a little more specifically, noting that the stakeholders representing disadvantaged populations are included in that leadership in the governance and decision-making structures, and asking ourselves who is missing. Now, one of the points about this is that these may not be data that are collected in the usual quantitative way, but they can be recorded and acted upon in the core documents of an agency and in the plans moving forward for emergency preparedness and pandemic response right now. Another example is under the area of community engagement. The initial indicator, as you see here, says the public health agency provides and or endorses education programs directed at the public to raise awareness about preparedness for relevant community risks. The prompt that we include is to make sure that those education programs are tailored for a variety of audiences in terms of format and delivery, so the mode of delivery. They take into consideration the languages spoken, different levels of literacy, cultural safety, availability of online technology, and other population level specifics. That education includes community actions that strengthen and draw from the resilience of the community itself. So within this report, we have repeated the entire table of 67 indicators developed by Khan and colleagues within their framework headings, and then added on these prompts so that they're right alongside. The wording may need some tweaking, and we'd be very interested in this third phase of the project to hear from all of you and from your colleagues about whether the wording that we've suggested makes sense, whether it resonates, and whether it needs some adjustment. We've also in the process of developing a bit of a dashboard. So here is the same information repeated again. Sorry, it's a little bit blurry. The original indicators, our equity prompts, and then an opportunity for you and your colleagues in an agency to check a box or color code it to see how well you're doing. And 67 indicators is a great many, so you may decide to work on one area at a time. Concentrate on a set of the indicators to see how you're doing and to measure your progress towards health equity. Excuse me. Sorry, I lost my mouse there. So in summary, what we're trying to encourage is that all of us are as explicit as possible about the age and sex of our population, if that's how it's measured, gender considerations also being very important, race and geographic location. There are specific prompts for First Nations, Inuit, and Métis communities to be considered wherever appropriate, which is probably everywhere. Race as well being important, as I mentioned, and to consider the factors that contribute to inequities and disadvantage. All of this can work towards including information about the strengths and resilience of the peoples, the communities, and the public health systems in which we work. And thanks to Claire